Toso. I'm a program officer at Johns Hopkins Center for Communication Programs. Today's discussion, assessing the impacts of combining community mobilization with supportive supervision to improve malaria case management behaviors, will be led by Dr. Ashis, the lead author of this study. We're also pleased to have Shelby Cash from the United States President's Malaria Initiative with us. If you'd like to follow along with the discussion guide or reference the study itself, you'll find links to both on the right-hand side of your screen, just above the chat box. All participants are on mute until the presentation ends and our discussion gets underway. This discussion is being recorded. If you are able to join us for the first Malaria Social and Behavior Change Evidence discussion, you can find that recording, this recording, and all future recordings on the Breakthrough Action website, as well as on our YouTube channel. We will be starting the discussion after a brief presentation. Please feel free to enter questions in the chat box at any time, and we'll address those as soon as the presentation is over. The goals of this evidence discussion series are to convene malaria as social and behavior change practitioners who are interested in learning from emerging research. We've made every effort to make sure these discussions are accessible to every level of comfort with research methods and terminology. Malaria SBC practitioners should be able to comfortably read, interpret, report on, and apply findings from peer-reviewed literature, and our goal is to help with that. We hope the discussion that follows will help practitioners envision pragmatic, rigorously designed activities. A word about the structure of these discussions. In each discussion, we'll pull an article from the Malaria Behavior Change Evidence Database. We'll also discuss each article from that database through the lens of the social ecological model. A little bit more about that in a minute. First, I'd like to introduce Shelby Cash from the President's Malaria Initiative and CDC to say a word or two about how today's discussion fits in with the U.S. President's Malaria Initiative's global strategy.
Thank you. Good day, everyone. The U.S. President's Initiative is happy to support this evidence discussion series, and I wanted to say a few words about how this fits into our global strategy. Over the past 12 years, our ability to collect data has increased exponentially, and we now have an opportunity to use the data to drive better outcomes. Therefore, enhanced use of data represents a core element of our global malaria community's strategy to accelerate progress towards malaria elimination. And this philosophy is also reflected in the WHO Global Technical Strategy for Malaria, which highlights improved surveillance and data-driven decision-making as one of the 3 key pillars of success. So while this often means country-level data collection, it should, in a broad sense, also mean taking data and lessons learned in other countries, and when appropriate, using it to inform our own country needs. From our perspective, regular discussion about rigorous malaria SBCC evidence builds and maintains capacity among the malaria community. And so we hope that this activity helps to meet your needs. Thank you.
Thank you, Shelby. We hope today's discussion shed lights on tips for reading and interpreting malaria SBC research for your own work. As mentioned earlier, today's article comes from an online searchable database of malaria SBCC evidence, which includes both peer-reviewed literature as well as gray literature. We would like to frame each discussion that we have around the social ecological model, which helps us explore decision-making at multiple levels. The evidence base we have just mentioned describes a growing body of research, findings that tell us behavior isn't the result of simply exchanging information with an individual. People make decisions based on a number of individual, social, and structural influences. A recurring theme in this evidence discussion series is a focus on interventions designed to influence multiple audiences and structures within this model. We've populated this slide with a few examples of factors at the individual, interpersonal, community, and societal levels that the study we're about to discuss today takes into account. So without any further ado, Dr. Ashis, welcome, and thank you for joining us today. The floor is yours.
Thank you so much, Mike. And hello, everyone. Good morning, afternoon, and evening, depending on where on the earth you are. I am really glad to be able to join this interesting discussion. And I'll be taking you initially through the paper. And as Mike has already pointed out, we'll be taking some questions and discussing more in detail. So we'll be going along with the discussion guide. I hope you have this. And here we are going to start answering the very first question on the discussion guide, which says, what evidence did authors collect and use to come to the conclusion that these approaches might be effective? So we set out this study with two major objectives. First one was to introduce intensive community mobilization activities targeted towards promoting usage of long-lasting insecticidal treated bed nets and timely care seeking for fever from a community level health worker. The second objective was to introduce supportive supervision of community health workers on effective malaria case management. As you will see coming ahead, they were combined in one arm to introduce a more effective ways of behavior change. The study was carried out in eastern India in 2 districts. These 2 districts have been identified by the National Malaria Control Program as highly endemic districts out of 50 such districts in the country. In each district, we selected randomly 2 sub-districts. Within each sub-districts, we divided the villages into 3 categories. First one was the control villages, where business as usual run by the government programs was going on. The second arm of this intervention, where we randomly selected 10 villages to introduce intensified community mobilization activities. And the third arm had the combined interventions, combining supportive supervision along with intensified community mobilization. So if you see in every sub-district, there were 3 arms, each consisting of 10 villages, and all these villages were randomly selected. So in total, there were 120 villages, 40 control, 40 mobilization, and 40 mobilization plus supportive supervision. Right, I have already spoken about this. So this is the chronology of events that took place due course of the study. There was a baseline survey in September 2009 where the households in those villages were surveyed to assess their behavior related to malaria prevention and treatment related activities. After the baseline survey, we did a formative research in December 2009 where we organized focus group discussions and key informant interviews to elicit the reasons behind the behaviors, the behavior communication channels, looking at local media, formal and informal ways of communicating health information. Utilizing that formative research, we designed this intervention, and after the formative research, we got the long-lasting bed nets delivered by the government in all arms equally. Similarly, all the community health workers in all arms were trained by the government and ensured that all of them had rapid diagnostic test kits and artemisinin combination therapy in place. The intervention ran for about 12 months for the calendar year 2010. After the intervention was over, the survey that was done at baseline was repeated with the similar instruments, in fact the same instruments, same methodology to make both rounds of surveys consistent. Now, in this section, we deal with the discussion questions 5, 6, and 7, where we talk about the study design, analysis, and generalizability. As I have already spoken a little bit, this study was designed as a cluster randomized control trial where the villages were clusters, and the trial had 3 arms. One arm was control, one was intervention only with community mobilization, and the other one was the combined intervention, combining community mobilization with supportive supervision. There were 2 rounds of household surveys before and after the intervention. During the survey, there was first a house listing of all households in those villages to know if there was any case of fever in the previous 2 weeks. Then out of that, 10 were randomly selected and interviewed for the household as well as individual level information on socio-demographic profile, about their health-seeking behavior. And from fever cases, we collected more in-depth information related to their last or most recent episode of fever. The sample size was determined by the proportion of fever cases tested for falciparum malaria within 24 hours and proportion of households utilizing bed nets, at least 1 bed nets correctly. The data was analyzed as an intention to treat analysis with the treatment centered at the cluster, which was the village level. The differences in outcomes between the arms was examined with logistic regression. As you may know, logistic regression helps when we have so many confounders and when we deal with large sample size and when we look at attribution of interventions. At the baseline, we looked at the socioeconomic status and they were not different. You could see that in the paper where we present the baseline balance. So the results were presented without any adjustment, since we did not see any socioeconomic difference at the baseline. In this section, we'll talk about discussion questions number 2, 3, and 4, which are about behavioral objectives, communication, and how did we measure the impact. So here we present the summary results. This one was for the use of bed nets. And when we mean use of bed nets, there was a specific question during the survey which asked their use of bed net the previous night of the survey. So as you can see, the rectangles, the blue rectangles on the table, they represent the intervention arms. The orange one is for the control. So when asked to the entire population, if they slept last night under a bed net. In the control arm, the response was about 79%. The community mobilization arm had 82%, whereas the combined intervention had 85%. And if you see the columns towards the right, they denote the statistical significance of difference in terms of odds ratio with the p-values. And we compare here both interventions individually with the control arm. And as you can see clearly, compared to control, both the interventions performed statistically significant and more positive way of health seeking. When we come to children under 5, we see for control it is 91%, for community mobilization 94%, whereas the combined intervention had 97%, pretty close to universal coverage for children under 5. And the differences were statistically significant. When we look at the sample that included women of childbearing age group, control had 94, community mobilization had 96, and the combined intervention had 97. The difference between the combined intervention and control was statistically significant. Here, let's take a look at diagnosis from a trained provider. What do we mean by trained provider? In this study, we defined a trained provider who has been trained by the government to provide treatment after undergoing a schedule of training, a modular training. So they included in our survey community health workers and facility level care providers. This excluded the informal providers or the private providers who were never trained by the government. So looking at the impact of the intervention, we see the total population, half in the control arm had a diagnosis from a trained provider for their recent episode of fever, whereas it was 59% for community mobilization and 61% for the combined intervention, which were statistically significant. Coming over to children under 5, we see 47 in control, whereas 63% in both the intervention arms. Here, the difference was statistically significant for the community mobilization versus control. And the combined intervention was pretty close to the level of significance. Coming to women of childbearing age group, we see 47 in control, 64 in community mobilization, and 61 in the combined intervention. And they were all statistically significant when compared with the control arm. So here we summarize the results of prevention as well as diagnosis and treatment. If you see the orange bars, they represent the control, and the blue ones, they represent the combined intervention. So here we see, well, we've gone through this earlier. You can only focus on the topmost part where it shows the numbers in blue. For instance, in the first one, use of LLIN, we see a 6 percentage point increase among the combined intervention compared to the control. Similarly, for diagnosis by a community health worker, we see 9 percentage points. For diagnosis, which we call as prompt diagnosis within 24 hours of onset of fever, it's marginally high, 1 percentage point. For diagnosis by a trained provider, it's 11 percentage point. And diagnosis by a community health provider, that was 15 percentage point. Coming to treatment, we see prompt treatment within 24 hours was 10 percentage points higher, whereas by a trained provider, it was 11 percentage points higher compared to the control arm. So here we present a breakdown of fever treatment by provider. For control, you could see the medical doctors, facility level medical doctors, they have 45 percentage, which means slightly below half went to medical doctors for treatment. And I would like to draw your attention to two specific areas. One was untrained provider that you could see on the left at 21% in orange, and community health worker on the right, which is 19%. So if we compare this with community mobilization, you could see, if you recall, let me take you back, from 21% untrained providers, it came down to 14%, whereas the community health worker, which was 19%, it went up to 28%. And for medical doctors, it was 45%, and it came down to 40%. We could discuss about the policy implications later. Moving on to the combined intervention, the untrained providers, if you recall in the control, it was 21, whereas here it came down to 11. And community health worker has gone up to 28. So it shows a shift on fever treatment seeking by the community towards more trained providers. Well, here we'll talk about the programmatic implications, focusing on strengths, weakness, validity, and methodological challenges. When we look at the programmatic implications, here, if you recall, we combined interventions, community level social and behavioral change, with trained and routinely supported health personnel. The health personnel were supported by another layer of supervisors to ensure their skill level was up to date. They were given regular supplies, and they were closely integrated with the community. So if you remember the pie charts towards the end, we could see a shift in people's care seeking from informal to more formal, or untrained to trained providers. And we did a cost effectiveness analysis of this intervention, and we found the combined intervention was cost effective when we compare with the number of cases promptly diagnosed. And as you can say, this saves enormous amount of money for the health system and improves the outcome for patients or the population. And the intervention on the community health workers clearly showed a shift from untrained to trained provider in timely care seeking, as well as prevention activities in terms of regular use of bed nets. The strength of this study was, well, it was a randomized controlled trial at the cluster level. And we also did a pre-post intervention analysis to compare the changes between 2 points of time. And since it was controlled, we had a strong counterfactual, which can say that what would have happened in the absence of the intervention. And the randomization here was performed at the cluster level, so it reduces bias in terms of selection, in terms of other confounding factors. And as we saw from the baseline analysis, we don't have this on the slides, but it is in the paper. There was not significant differences between the arms related to socio-demographic characteristics. Similarly, there were not much differences statistically between the control and the interventions in terms of the access. So if you recall, we got the supplies like the bed nets delivered equally to all intervention and control villages. So the changes or the impact of the intervention cannot be simply attributed to lack of supplies or reduced access. So here I am going to talk about the lessons learned. Based on this study, what we found, doing a formative research at the beginning gives a more contextual understanding of the interventions and the populations. So one can align them very well. First, to design key messages. Second, to design the delivery strategy of communication to those populations, adapted to local social and cultural norms. Then the methods that are globally proven, such as RDT, ACT, and long-lasting bed nets, they were introduced with local adaptation. So global knowledge plus local adaptation leads to achieving public health goals, which is not new. You would have seen in other cases also. But what is important here is the contextualization or the local adaptation. The community health workers were empowered with supervision and communication skills, which helped them to build trust with the communities and get more integrated. And a little bit background about community health workers in India. It's a huge army of community-based health workers who are women. And this was the first time systematically the government tried to engage them with the malaria service provision, utilizing RDT and ACT. So that's why it was very high on the agenda of the government to ensure whatever we are going to try with them, make sure we try with a golden case scenario, then learn lessons from that and utilize that to scale up the strategy. Finally, shifting fever cases that are complicated from the facilities to the community level treatment provider. As we saw, the cases were reducing from medical doctors and increasing at the community health worker level. So it can increase the efficiency of the health system, increase the cost effectiveness, and will reduce the cost of the patients if we factor in patients' travel time and indirect costs such as loss of wage or some accompanying person going with the patient to the health facility and so on. I think Mike will take forward from here.
Thank you so much, Dr. Das. So now we're going to go and start a discussion. If you'd like to type your questions or comments into the chat box, we can take your feedback there. Also, if you'd like to speak with a group, if you can click the raised hand icon on the top of your screen, we'll turn your mic on, and we can have a discussion that way as well. So to start off, it looks like we have a question from Tito, and he's asking, the interventions were said to be conducted by the government. Did the government fund the baseline and endline survey as well? I'll pass that over to Dr. Doss.
Thank you, Tito, for this great question. So, in a way, it was not funded by the government. It was funded by an impact evaluation trust fund, which was independent of the government. So if the question was the funding plus the independence of the survey, they were completely different. So there was no funding from the government, in short.
Thanks, Dr. Doss. It looks like we have a second question from Caroline Hilary.
Yeah.
She's asking, it seems that the main rise in behaviors was due to community mobilization. The additional supportive supervision strategy seems to have given only marginal gains. Do you agree?
Well, this is another great question. We haven't done any analysis between the community mobilization and the combined strategy. So it's a bit difficult to say, but compared to control, as you can see, we see changes. So yeah, it's a bit difficult to present that fact now since we don't have evidence. At this point, what I can see, we need to do some additional analysis to check that statement. I see another question.
Yeah, this one's coming from Anna Helland, and she's asking about what sort of, you'd mentioned that there was formative research that was used to design these particular interventions. Maybe you could talk a little bit about that formative research?
Yeah, sure. Thank you, Anna. So in this formative research, we undertook qualitative research and we interviewed community members as well as community level decision makers such as the politically represented leaders, village heads, school teachers, religious leaders, women's group, and mothers groups to get an idea about the overall health-seeking behavior in the community with respect to malaria and what are the barriers they feel that would be helpful to overcome if they wish to access the optimal level of care. So we organize focus groups among larger groups like this women's groups and mothers groups, whereas we organized in-depth key informant interviews for the key decision makers at the community level. This included also the community level service providers, both from the formal as well as informal sector. Okay.
Thanks, Dr. Doss. It looks like we've got another question from Laura. If there were any special procedures used by the community health workers to approach the mothers and convince them to change behaviors.
Right. So the community health workers, they had a schedule of visits, and the way it was designed, well, it was not designed by us. The community health worker program is well defined by the government. So every day they are supposed to visit few households in their routine visit, and they would sit with them and discuss with them the community mobilization strategy and delivery. In simple, they would educate them about positive health-seeking behaviors, such as regular use of bed net and prompt care seeking by mothers for their kids as well as for their family members in case there was a case of fever. Yeah.
So it looks like we have another question from Wani in Sierra Leone. She's asking about how to improve the competency of community health workers. And maybe, Dr. Das, before you address that, I just want to point out this is actually something that's been studied rather thoroughly by Alex Rowe from the CDC, who in both 2005 and recently just this last year published systematic reviews on how to maintain a high quality performance of health workers. And I think it's just interesting to point out that the lessons that he learned, specifically in the 2018 paper were that feedback as well as multifaceted interventions and supervision with audit were some of the common things that led to greater impact. And I'm just wondering, having read the paper, I know that these are all parts of the intervention, but could you speak a little bit more about what the supportive supervision in this study, what that entailed?
Okay, sure. Thank you, Wani, for your question. So the important thing that I have learned through this study, first is training of the health workers to improve their competence. The training, what we did, or what it was designed by the government, it was a modular training. The community health workers had 4 modules. They would have a couple of days of training, go back to their villages, come back after a few days, and with some take-home assignments. And they were regularly supervised by community health supervisors. So training is important. It is very crucial. The second is ongoing capacity building through supervisors, making sure they understand the messages or the training and they implement it very well. Third is very important, having regular supply of commodities. We have seen in cases where community health workers are well trained, but they don't have commodities, that demotivates them to perform. Yeah, so training, continuous capacity building, and regular availability of commodities are the takeaway messages from our intervention.
Thank you, Dr. Das. It looks like one of the questions we have sort of follows up with what you just said. Can you speak to how the stockouts of commodities were monitored?
Right. Great question. This was monitored by the community health supervisors. They had a schedule of visit every fortnight to visit every community health worker to monitor their availability of commodities. And in addition, the community health workers were also supposed to visit the health facility at least once in a month for their monthly meeting. So these were the avenues where we tracked the availability of commodities and ensured that they were available regularly. And just want to make sure that this was done as part of the government program across all intervention arms. So it was not that the intervention tried to specifically ensure that commodities were available only in the intervention arms.
Thanks. And also, so we've got another question here about logistical regression. And it looks like Abdul would like to know if you feel that there were any residual confounders.
We, in fact, did not look at the residual confounders, but the common confounders that one could encounter related to socio-demographic variables, they were all balanced in the baseline. So we did not put them in the final model of analysis.
And it looks like Jane's raising a really great question as well. See, in all sorts of countries, when you have community health workers sort of serving as the backbone of community health, what was it particularly in this situation that motivated the health workers? Were they paid?
So in this case, as part of the intervention, we did not have any payment mechanism. But as a part of the government's program, they were given certain incentives based on the tests they performed. And that was common across all intervention arms. So when Well, something apart from this study, I have published another paper along with a couple of other experts on community health workers' motivation, with a focus on the similar group of workers in India. And what we found, the motivation is twofold. It includes both monetary and non-monetary. Of course, monetary part is important. Which is equally important is the non-monetary, where they feel they are cared or they are connected with the health system through regular supervisions, regular reviews and audits. Audit in not in a sense of assessing their compliance. It's more in a sense of feeling that, making them feel that they're part of the health system. And also, people who are the local level decision makers, as I told earlier, the village level or the religious leaders, they regularly maintain the relationship and strengthen the partnership between the community and the community health worker. So yeah, to summarize, both are important, monetary and non-monetary. And their career path, the question on career path, till the time we did this study, they did not have any path beyond being a community health worker. And during the selection, it was made very clear to them that they were not promised any kind of career path. They would be a community level service provider and serve their community. And most of the ladies who were CHWs, they had already history of serving their communities in some way or the other through some social enterprise group. So I would say they were already motivated to continue their work forward.
And if you don't mind, I'd just like to add, one of the things that I thought was really interesting in the study was part of the reason it seems to make such sense to use and work with women's groups is that very much like sub-Saharan Africa, the rainy season coincides with sort of the lean season as well, as a time when food is the millet's still on the stalks and you don't have your harvest yet. And so sort of a cruel situation when you have very sick people with malaria that don't have access to the sort of resources that they would normally have. And in the paper, it noted that these women's groups are often microfinance groups. And so the same groups that you might go to get resources to solve your problem would be the groups, and it would be the place where you could go and get treatment. We've got a question here. Dr. Das, would you mind talking a little bit more about what happened in the community mobilization?
Right. So as I described about the formative research, we found the groups to target were the general households, meaning the entire village, also targeting pregnant women and women in general through microfinance groups or community enterprise as we call, or self-help groups, then target children through their teachers. So they were the target groups. The strategies we used, one was informal level meetings, organized every fortnight, a meeting among the community level, among the self-help groups, which was not an additional job because they were supposed to meet once every week as part of their routine activity. So the community health worker just had to be present there along with our community mobilization team to discuss about healthy practices, healthy treatment-seeking behavior when it comes to malaria prevention and treatment. It was a group meeting. At the school level, it was the teacher who was additionally trained to talk about healthy behavior as far as malaria is concerned. And third one was multimedia, where we showed them shows by carrying a mobile multimedia van. We ran movies in local language which were appropriate to the local culture. They were in fact designed contextualizing the local situation. Yeah, so these were the mobilization strategies we used. It include community level group mobilization as well as using high-tech multimedia techniques.
We've got another question here from Ibrahim, and he's asking, part of the question is, was there information collected about resistance from households? Did you get anything from the formative research that led you to change, adapt, or come up with specific strategies, whether it was for care seeking or nets, that had to do with findings related to resistance?
Right. This is a great question, and this came up very significantly during our formative research, that some households had resistance to usage of mosquito nets. Well, we published the formative research as a qualitative paper. It is referenced in the same paper as well. And there we found people had resistance to using bed nets because they felt it was hot inside the bed net. Some felt suffocated, and some felt it was not essential. Some felt, in fact, some developed innovative uses of mosquito nets before we did our intervention, like using the bed nets as fishing nets. So what we did in the mobilization strategy or in our communication strategy, we addressed each of these resistance by giving valid evidence. For instance, people, when they told we felt very hot or humid inside the bed nets, we try to compare, put a different scenario. If you get malaria, what would happen to you? So just compare the level of discomfort between sleeping under a bed net, which is hot, versus suffering from malaria, which can even be fatal. So presenting them alternate scenarios and working through the group leaders, it helped us to change their behavior.
Thank you. We've got another comment here from Taylor Price. So it looks as though the interventions were quite successful. And are some of the tools that you used, whether it was the surveys, for the supportive supervision visits, how they were done or what was involved, the net monitoring, community mobilization, are any of these available for use and adaptation by others?
Well, I could share them personally if you ask. In the paper, it talks about in detail about the mobilization activities. And it also, the qualitative paper I spoke earlier, it also talks about the behaviors that we try to change. And yeah, so the tools can be available if requested. We can share those.
Thank you. And just as a note, when we get to the very end of the discussion here, there's going to be a slide that has Dr. Das's email on it. So if you'd like to get a hold of him and ask for those, you can do it that way. We've got a question from a colleague in Madagascar. Mama Tiana is asking a little bit more about the supportive supervision. I know you described that a little bit earlier, but maybe a little bit more detail about how it was designed and carried out.
Okay, yeah. The supportive supervision, the community health workers were supervised by community health supervisors, and they were assigned around 10 to 15 community health workers per supervisor. They would visit them during the initial phase of the intervention. They were visited twice a week. After that, it became weekly and fortnightly. During every visit, they would discuss with the community health workers the issues and challenges they are facing. They would check their drug stocks, commodities. They would re-emphasize the training points on appropriate care-seeking behavior, whether it is on prevention or treatment. And they would also help them by accompanying them to household visits, and in a way build their capacity more on communication in general as well as the health communication. And they had a checklist, the supervisors. They would ensure everything has been followed as per the checklist. And yeah, so that was, and they would report to the project team leader for review. So yeah, this was in short the activities, but in general, it was technical capacity building on treatment of malaria. For instance, if they were diagnosing, if some fever case came, the supervisor would help to make sure they're doing the RDTs correctly. They're giving correct doses of ACT based on the schedule. This was all supervised.
Thank you, Dr. Duff. This is out for everyone. His email is also included on the paper that's attached. But I do have a question for you, Dr. Doss, particularly related to your comments about cost effectiveness, because this is something that's extremely important for PMI, and as we continue to implement different interventions, we want to also have some understanding about what cost savings are for the different activities we implement. So could you talk a little bit more about what methods you might have used to analyze the cost, and what types of cost savings you actually saw between the different intervention groups?
Right. So thank you, Shelby, for your question. The paper itself mentions about a cost effectiveness analysis that we undertook, and it is attached as an appendix to the paper. So here we compared the cost that the project incurred as part of the intervention compared to the regular government program, and the cost difference, or the incremental cost effectiveness ratio, as you would say, between the arms was compared with the effectiveness, and the effectiveness was measured prompt treatment as well as sleeping under a bed net. So how many additional people slept under a bed net per every dollar spent. And here, when we did the costing, we approached from a systems perspective. There could have been costs from the household additionally that we did not measure. And we only measured the variable cost. We did not measure the fixed cost. For instance, having a facility, the facility's regular running cost, we did not do that. Rather, we compared only the additional cost related to community mobilization activities and supportive supervision. And using these techniques, we found our intervention was cost effective than the government program or the routine activities when compared with the additional number of people that sought prompt care and the additional number of people they slept under a bed net.
Thanks, Dr. Dotz. I'd like to point out as well that if you click on the link in the resources box just above the chat, in the article itself, there's an appendix that has a complete and detailed breakdown of the cost analysis. Also to point out that a similar study in Kenya also found roughly about the same price breakdown. So going back to the chat box, we do have another question from Wani. She's asking about the monitoring of the use of nets in the villages.
Okay. Right. So the monitoring of utilization, there are two things. One that was done as part of the research, the survey. It was done twice, before and after the intervention. But if you mean the regular monitoring of utilization. So it was done by the community health worker herself. And the community health worker, being a lady and from the same community, she had access to every household. And if you go back to the history of selection of community health workers in India, this particular group, they are known as accredited social health activist, or ASHA, which is the formal community health worker program. They were selected by the community. So the community also had ownership of selecting ASHA or the community health worker. So they had access to the households, and as a part of the monitoring, it was decided and agreed upon by the villagers that the community health worker can randomly visit their household even at night to verify if the bed net was used properly.
Thank you. So we've opened up the mics. If anyone wants to comment or ask any questions in person, all you have to do is click on the green microphone on the top of your screen. Is there anyone have any comments they'd like to make?
Hi, this is Elizabeth Solomechos. I just wanted to appreciate Dr. Das's presentation today. It was excellent, and the findings were very, very interesting, as was the discussion. So thank you on behalf of myself and the rest of the team.
All right, we are just about at time. So before we wrap up, just a real quick breakdown. I wanted to remind everyone that the resources, about the resources we mentioned earlier. The Malaria Social Behavior Change Evidence Database has not only links to articles like the study that Dr. Das just shared, but there are also infographics that you can use that show the impact that social behavior change has had on net use, different behavior change strategies that have been used to influence service providers' behaviors, as well as malaria case management. In addition to the infographics, we also have a number of fact sheets that are based on this database that synthesize the key findings from over 3,600 peer-reviewed articles, 1,700 gray literature reports. The fact sheets are presented in 3 malaria technical areas: net use, case management, and service providers. And with that, we'll thank Dr. Das for his presentation. Thank you, everyone else, for joining us. If you wouldn't mind to stick around for just a second and fill out the polls that you see on your screen, we'd really appreciate it. Thank you.
Thank you, everyone. Thank you, Mike.